que es una compañía estadounidense con la que hemos empezado a colaborar recientemente. Entonces, ellos han desarrollado, que es lo que estamos presentando, un software basado en inteligencia artificial que nos permite realizar un diagnóstico de las arterias coronarias de manera no invasiva. En estos momentos único en el mercado. Sobre todo, y la más importante, es que aquellos pacientes que cuando el diagnóstico convencional no aclara bien si la enfermedad coronaria es relevante o no, irían a la sala de hemodinámica directamente, y esto nos permite minimizar los riesgos del paciente, evitando así que entre en la sala de hemodinámica, sobre todo en aquellos casos en los que el diagnóstico da un resultado negativo. Por otro lado, además, evita también los falsos negativos. Hay muchas pruebas convencionales que denotan que ese paciente no debería ser tratado, o en algunos de los casos, y enviamos a esos pacientes a casa con enfermedad coronaria que posteriormente acabarán volviendo al hospital o muriendo sin ser tratados.
My personal experience with FFRCT starts a lot of years ago, about 10 years ago. And my first experience was with the platform trial in which we have tested the cost effectiveness of the FFRCT in clinical practice. This kind of evidence convinced us that when we use CT plus FFRCT as gatekeeper for invasive coronary angiography, we can cancel a lot of invasive evaluation in order to treat medically this patient. This means a huge reduction of the overall cost of management of a patient with ischemic heart disease, and this data were also confirmed by the randomized trial, precise trial that was just published a few months ago. This is the most robust evidence that we have in our hands in order to use this technique in our daily practice. The first goal of FFRCT, exactly like cardiac CT, is to rule out the presence of functionally significant coronary artery disease. In terms of negative predictive value, is extremely high, and this means that when you have an obstruction at the level of coronary arteries, but you have a negative FFR, this is a safe condition to decide that the patient doesn't need to be further evaluated with invasive coronary angiography. Of course, there are situations in which FFRCT is positive. The evaluation of positivity of FFRCT is a complex puzzle of numbers that you need to interpret, and according to this value, you can optimize the decision to refer to the cut or avoid the cut. And also now there is the emerging evidence that all this information are not only useful for diagnosis, but also they are useful for the planning how to treat this patient.
That's a great question, and I guess it's one which I won't be able to definitively answer, and it's also one that requires an elaborate answer. So let me start by telling you what we do know currently. So by implementing FFRCT into your daily clinical practice, what you will get is the ability to titrate your population, meaning you're going to be able to disregard to 60% of patients who's going to have a great prognosis. That leaves you with 40% of patients who we can define as being potentially high risk. Our data seems to suggest that for some of these patients it might be beneficial to perform revascularization based on the FFRCT result that will lead to improved prognosis for these patients. But there's such a wide array of patients within this patient group, and some may benefit from different treatment algorithms. So what I think we can do in terms of now and in the future is we have the ability to also implement AI QCPA data. That is coronary plaque assessment data. And if we combine that with FFRCT, I hope that we're going to be able to further increase the reduction in mortality based on intensified and stratified medical therapy, on top of also being able to refer the correct patients to the catheter lab. So that's a really good question, and it's perhaps one of the most important questions that you can ask when it comes to patients with stable angina, because overall their prognosis is going to be pretty good. What I think is it's twofold, right? So if you can tell the patient you have a normal FFRCT analysis, so you're going to have a really good prognosis, and some of our most recent data would also suggest that they're going to have very few symptoms. So that's going to be a major increase in their quality of life, knowing that they are quite healthy despite having coronary artery disease. And then again, you have the patients that have an abnormal test result. And what our data indicates is that you're able to stratify your medical therapy, the anti-anginal treatment, by identifying patients that have significant diffuse disease, and you can also reduce symptoms, thereby increasing quality of life by identifying patients that have significant focal disease, which may give them symptomatic benefits if they go to the catheter lab and have a PCI.